All right. Please find your seats to continue this wonderful journey, understanding consciousness. And let me start by apologizing to Dr. Aurélie Soria Frisch from StarLab here in Barcelona, because you had a flash talk. We all waited for that, and it was somehow overseen. So we will start with that right now. And also, I should, for the speakers, remind that just when we'll have the coffee break, and that should be at 3:30, we'll take a picture on the stage of all the speakers and presenters. So please try to remain here for that historical picture. Right. Without further ado, Aurélie, talking about consciousness studies in the electrical brain, and that is part of actually our collaboration within Luminous. Thanks, Aurélie.
Thank you, Steven, and for the opportunity to take over 5 minutes. I'm reporting here on the project Luminous. You have seen the part of computational neuroscience modeling, which is included in the project. This is a collective effort of different institutions, the University of Milan, the Coma Science Group in Belgium, the University of Tübingen, the IFADO Center in Dortmund, the University of Oxford, and the INSERM Center in Rennes. And StarLab is coordinating, and I have the pleasure to coordinate all these people, and sometimes also the pain, but mostly the pleasure. StarLab is a small company in Barcelona, founded in 2000. We understand ourselves as a tech transfer company. In this case, what we are trying to do is simplifying all technologies for measuring and altering consciousness. In the case of the project, focusing on consciousness. And this is our vision. Fabrice was already mentioning it, so that someday consciousness will be measured electromagnetically and can be altered by electromagnetic stimulation. So our questions are these. The first one is, what is consciousness? So we have a theoretical strand in the project, which have analyzed different theories of consciousness. You have the deliverable of this review of the state of the art in the website of the project. All the work in computational neuroscience that Fabrice was mentioning that can have help us to associate this thalamocortical connectivity to the wakefulness axis of this very nice plot by Stephen Loris in 2005, where you have the different states of consciousness and the cortical-cortical connectivity to the awareness axis. This was one idea that I found very nice within the project. And because what we are trying is to characterize these different states of consciousness with different metrics. So can it be measured? And of course, there are already some approaches for measuring or quantitatively characterizing consciousness, the perturbational complexity index, which was proposed by Marcello Massimino and colleagues. But it has some problems, basically the bulkiness of the devices that are used, and as well as the recording time. And besides this, it's also a binary measure. So it establishes like a threshold here for distinguishing consciousness from non-consciousness. And we would like to go beyond in the project and to find out some continuous measure of this consciousness. How are we doing this? Marcello and his group is trying to simplify the computation of the PCI, but other works are based on LZW, computed on spontaneous EEG activity. You can see here in the example of disorders of consciousness, you have here healthies, MCS, and UWS. As you can see, by computing the LZW, which is a proxy of the Kolmogorov complexity, you can find statistical differences between these groups. And not only, but also correlated, it has been correlated with a particular index, which is called SWAS, which was proposed by the University of Oxford for anesthesia studies. We are also studying consciousness in fetus by analyzing MEG activity. We have a longitudinal study that is ongoing from the week 24 to the 48th week of gestation. And we are applying there the local global paradigm that we can compare with data that it's being acquired in the project with adults in wakefulness and sleep. And the last question is, can we use electromagnetic stimulation to modify the consciousness states? Basically, two studies I would like to present you. The first one is stimulation with TDCS on the frontoparietal network over 46 dog patients. Of them, 6 responded positively. You have here the summary in this table of their responses. This was just one session of TDCS. And now we are working on all the technological apparatus to conduct a closed-loop study based on a particular feature, vigilance feature, which is called spectral entropy, which oscillates, indicating changes in the vigilance states. So the idea is to apply different types of stimulation in the upper and in the lower vigilance states. And these are the first data acquisition over one of the patients. There are several problems because these are very long recordings, so the patients are treated at the same time, so you have several types of artifacts. And we are disseminating this among the general public. This was a session we did here at Caixa Forum in February, basically inviting other frameworks of consciousness like a cultural anthropologist, like a meditation master, and like a quantum physicist, trying to find out common answers. And one thing that captures my attention is that we, in the Western tradition, we are most focused in all these kind of states, while there are other traditions that focus more on the wakefulness and the different levels of consciousness that you can achieve in this wakefulness state. Thank you very much.
Thank you so much. Time for a flash question from the audience. If not, thank you again. Next time.
For the 5 minutes.
So now it's my pleasure to introduce my co-chair. I said it before and I will emphasize it again. We need more women brains in HBP, so it's especially special to introduce Olivia Gosseries from Belgium, Coma Science Group, and she will start this session where we talk about clinical, ethical, and societal implications of consciousness research. Olivia.
Thank you. So I will start with a description of all the different disorders of consciousness to have everyone on the same board. But before that, I would like to introduce you the Coma Science Group, which is led by Stephen Lowrace. And as you can see, there are many people. There are physicians, neuropsychologists, engineer, biologists, physical therapists, speech therapists, nurse, and computer scientists. And we are all there to learn and to study the damaged brain. So, how do we get there? After severe brain injury, patients fall into a coma. A coma, it's an acute state. It only lasts a few hours to a few days, and sometimes a few weeks if it's a pharmacological coma. In that state, the patient never, ever, ever open the eyes. The eyes are always closed, and they only show reflex behavior. So they are not conscious of themselves or the environment. If the brain lesions are very severe, then the patient will pass away. If not, at some point, he will open the eyes, but remain unconscious. And that's what we call the unresponsive wakefulness syndrome. So that's patients who are not responsive, but awake. Before, we used the term vegetative state, or VS, but we recommend not to use it because it has a very negative connotation, and so we prefer a more neutral term. So please say unresponsive and not vegetative. Then, once the patient starts to recover some sign of consciousness, then he enters into a minimally conscious state, as Aurore showed yesterday in her flash talk. And this is patients who can be categorized in MCS plus or minus, depending on the presence or absence of language. So in the case of MCS plus, they can respond to command. So if I ask them to squeeze my hand, to move the legs, they will do it 3 out of 4 times. So it has to be repetitive. And it can also be intentional communication or verbal intelligibilization. And if not, if they show other signs of consciousness that are not related to language, then they are in a minimally conscious state minus. So this is, for instance, patients who have visual pursuit. And so you should all move your head and look at me. So that means you're conscious. If not, that's probably mean you're doing something else or not listening to me. It can also be localization to pain. So if I take a pen and I squeeze on your fingertip, then you will remove your hand and touch the point of localization. So that's another sign of consciousness. And this categorization has been also paralleled with the metabolism of the brain. And you can see here it's the PET scan. So we look at the glucose metabolism. And we see that patients who are minimally conscious plus, they don't have hypometabolism in the left language hemisphere. Whereas the patients who have language troubles, they do show some hypometabolism there. So the thing is, all those patients, they cannot communicate. So they cannot report anything. We cannot ask them how they feel, if they feel pain. So this is really important then to try to find a way to see if they are conscious and somehow to try to find other ways to communicate with them. But then once they can communicate, or functionally, or they can use objects in a functional way, then we say they emerge from the minimally conscious states, or exit MCS. And sometimes, in rare case actually, we have patients who usually have a stroke in the brainstem here, and then they are fully conscious, but they are fully paralyzed too. So it's locked-in syndrome. They have preservation of the cognition. It's just the motor pathway that is blocked. And usually they can communicate with vertical eye movement. So you can still say, okay, if you want to say yes, look up. If you want to say no, close your eyes. And then more recently, we also observed that some patients who are unresponsive at the bedside, they actually show neuroimaging results that are more compatible with consciousness or with minimally conscious states. So for those patients, we suggest to use the term MCS star as the diagnosis with neuroimaging, or cognitive motor dissociation that was introduced by Niko Schiff, and that's going to be the next talk. So as you see, there was a lot of different category, and it's very difficult sometimes to detect consciousness at the bedside. And indeed, there are several studies that now show that there is a high misdiagnosis. In that study, we assessed 126 post-comatose patients, and we asked the clinical team, what do you think of the diagnosis? Are they conscious or not conscious? And in 51 cases, they said the clinical consensus was unresponsive, UWS. Then we went to see those patients, and we assessed them with the Coma Recovery Scale Revised, which is a scale that has been specifically developed by Giacchino in the US to differentiate between unresponsive and minimally conscious. So as you can see here, it assesses audition, vision, motricity, verbal function, communication and arousal, and depending on the presence or absence of certain item, then the patient is considered minimally conscious or not. And then using that scale, with those patients, we noticed that 18 of them out of the 51 actually show some sign of consciousness, which led to a misdiagnosis of 30 to 40%. So in 1/3 of the case, you think the patient is not there, while he's actually potentially there. So why such a high rate of misdiagnosis? Well, first, on the patient side, it can be because he's paralyzed, he can be because he doesn't understand, he has sensory deficit, like blindness or deafness, he has fluctuation of vigilance. They have that very much, so at some point they can fall asleep or be drowsy, and so that's why they don't answer to you. They can also have pain or medical complication like subclinical seizure or infection, or they can have sedative that makes them drowsy again, or sometimes, as all human beings, they don't want to collaborate. And then on the assessor side, as we just saw, we have to use a standardized scale. But then we also should use some specific tools. So for instance, if you want to assess the visual pursuit, it's better to use a mirror than me walking in the place, because it's dynamic and autoreferential. Same thing if we want to assess localization to sound, it's better to use the own name rather than just the sound of a bell. And then you also need to know what are considered as signs of consciousness. For instance, blinking to breath is not considered as a sign of consciousness. And actually here, among that scale, we see that there are some items that can categorize 99% of the patient in minimally conscious states. And so those are the movement to command, the visual pursuit, fixation, automatic motor response. So that's like when you're scratching your nose or when you're pulling the tracheotomy, for instance. And then localization to pain, as we said before, and intentional communication. But maybe there are other signs of consciousness. Could you think about one, or two, or three that we could assess at the bedside? No one? Okay, I have two for you. Resistance to eye opening. So some patients, they fall asleep when we do the assessment, and so sometimes we try to open their eyes manually, and some of them, they resist like this. So we wonder, is that a sign of consciousness? So we looked in our population, we had 79 patients, and 24% have this behavior. And if you see, there's like a relationship between the level of consciousness and the presence of resistance to eye opening. But still, we have 6 patients considered unresponsive who show that behavior. So then that would mean, but then it's not a sign of consciousness. But then if you look at the brain metabolism of those 6 patients, you see that 5 of them have more brain metabolism or fMRI activation that is more typical of minimally conscious states than unresponsive states. So for instance, we look at this one, it's 3 different views of the brain, and you see in green, yellow, that there is some partial preservation as compared to like this one or this one who's totally blue. And this is with fMRI active paradigm that we will talk about a bit later too. The second other sign, potential sign, is oral feeding. Do you think you need to be conscious to eat, to swallow? We were wondering, and so we look at all our unresponsive patients, we had 62, and we saw that 2 could actually swallow and eat food. So that's only 3% of the population. And in the first case, we see that this is more typical of unresponsive patient. So he had hypometabolism in the entire brain, and the diffusion tensor imaging that looks at the white matter tract is damaged, especially here in the front. But this patient could only swallow liquid, not solid food. The patient number 2, he could eat solid food. So actually he could have the oral phase, malax, and then swallow. And we see here a completely different picture where he had preservation of metabolism and then a better structure. So we think that could be considered as a sign of consciousness. Then, why is it so important to differentiate between someone who's conscious and someone who's not conscious? Well, first, for diagnosis purposes. If you're conscious, you have better chance to recover than if you're not. And this is a study out of with 800 patients. And if you take unresponsive patient 1 month after the accident, and then you look 1 year later, you see that the majority of the patient will die if they have a non-traumatic etiology, so a cardiac arrest or a stroke, for instance. But if after 1 month the patient is diagnosed as minimally conscious state, we see that 1 year later he has more chance to recover than to pass away, and some also remain in the same state. The second thing why it's important to diagnose is the treatment. Patients who have minimal conscious states tends to benefit more of treatment than if they are unconscious. And this is, for instance, when you use deep brain stimulation, where you implant an electrode in the thalamus, and then it has shown with Niko Schiff's seminal paper in Nature that you can recover some behavior. And similarly with TDCS, 50% of the patients who are minimally conscious can recover some sign of consciousness. And this is the work of Aurore from our team. And then it's ethic also. There are ethical challenges, and depending on if you think that a patient is conscious or not, you will behave differently, and you will have different opinion. So this is something we can do together. For you, now that you know the distinction, is it acceptable to stop treatment in a patient who is in a minimally conscious state? Yes or no? And do you have the same response if it's acceptable to stop treatment if it's an unconscious patient? You see here that we ask lots of health professionals, and that the response is different. For them, it's 70% acceptable if the patient is unresponsive, but it's only 30% acceptable if they are minimally conscious. The same if we switch, and if you were in that state, would you like to stay in that state? Yes, no? Here we see that most of the people, they don't want. Less than 2/3 would not like to stay like this, but again, we have less people who want to stay in unresponsive patient than in minimally conscious patient. And if you don't know, you should think about it, and you should also check with your relative what they think and what they would like to do. Okay, so going back to the conference theme, consciousness, what have we learned about that studying coma and post-coma patients? First of all, is that consciousness is not responsiveness. You can have someone who's not responding to you, but still conscious. And here it's 2 case reports. In Liège, we assess patients almost every week, and they come for a week. We do behavioral assessment and neuroimaging assessment with them. And then here it's 2 cases. The case number 1, it's a woman who had a cardiac arrest during delivery, like 6 years ago, 6 years before she came. And the second one had a stroke, also like 6 or 7 years before she came. And at the bedside, they were both unresponsive. So we tried 5 coma recovery scale. There was no sign of consciousness at all at the bedside, and hence they had very different pattern. In case number 1, it's actually typical of the unresponsive state. So if we look again at the positron emission tomography, we see that everything is blue, though the brain metabolism is very down. We look at the fMRI resting state default mode network, it's absent. Then we look at the white matter track, and we see again it's very severely damaged, and especially here again at the front. And then we tried the mental imagery task, like imagine playing tennis and imagine moving into your house, and then there was no brain activation. So this was more confirming that the patient was unresponsive. But in the second case, we see a totally different picture again, with like preserved metabolism, preserved or half-preserved default mode network, preserved white matter, and she could also play tennis and play and move into her house in the fMRI scanner. So in one case, we confirm to the family that the patient was unresponsive, and the other case, we say that the patient was actually conscious or minimally conscious star. And so we see the family before they come, while they are in the hospital and after. And the case number 1 here, we will more tend to discuss about end-of-life decision. If this is what the patient would have liked, because it's been at least 5 years that she's in that state and there's no hope of recovery, then we would tend to say, okay, if something happened, if there's a pneumonia or if there's a cardiac arrest, we let her go. But in the case here, well, we know that she's clearly more conscious than what we think. So then we will try to stimulate more at the bedside, or do brain stimulation, or to try to find a response to command using EMG, and at the end, try to find a way to communicate. Then, consciousness, it's not responsiveness, but it's also not global brain function. So this is an old review by Stephen. You and me, right now, if you're still there, we have 100% of our brain metabolism. Then, when we die, we will all get there at some point, sooner or later, then we have 0% of our brain metabolism. Tonight, when you go to sleep, in deep sleep, you have a decrease of 50%. Then, when you start dreaming early in the morning, you recover some global metabolism, almost as in wakefulness. Then in general anesthesia, you have again a massive drop. And then if you have a good anesthesiologist, you recover. And then if you're in an unresponsive state, I should change this. Then you also have a massive drop. But then sometimes when they recover, they don't recover full function, full metabolism. Though that means in the brain there must be some areas that are more important for consciousness. What about primary cortices? So here it's a study with the noxious electrical stimulation, but it's the same if you have an auditory input. So you and me, if we have a laser on the hand that's painful, then we will activate the pain matrix. In brain dead people, there's no activation. And then in unresponsive patients, they do have activation, but it remains in the primary cortices and it doesn't spread in the brain. Whereas patients in minimally conscious states, they will show the partial pain matrix activation similar to the one we observe in healthy controls. So again, minimally conscious patients feel pain and should have medication if they have some sign of pain at the bedside. Then we also have another study where we look again at the brain metabolism, and at the end we say consciousness is related to this frontoparietal network, which has also been shown in other population and with other paradigm and other techniques. But basically here on a large cohort, we observe that unresponsive patients, they have a bilateral hypometabolism in the frontoparietal network. Whereas the patient in minimally conscious states, they have some preservation of this frontoparietal network, as we can see here in red, in the parietal and a bit of frontal. But still, in 32% of the cases, when we assess patients at the bedside, they are unresponsive, but in 32%, they still show a brain activation that is similar to that. So probably they are more conscious than what we think. So after frontoparietal network, what's also important, and we've seen it also in the previous talks, is the thalamocortical loops. So in a seminal paper of Stephen, we show that the recovery of consciousness at the bedside is also linked to the recovery of the connection between the frontal area and the thalamus. And similarly, if you stimulate the brain directly with deep brain stimulation, you also show behavior improvement. Then consciousness is also related to connectivity. So this is a study by Atina, who's here. And we can, again, we've seen that in the previous talk, but you have different resting state network with the fMRI. And here we can see a relationship between the level of consciousness and the integrity of this network. So it can be default mode network, or auditory network, or visual network. And you see that in minimally conscious patients, they have a preservation of the network, whereas in unresponsive, sometimes it's a little bit or absent, and in coma, it's totally absent. Then you can also assess resting state with the EEG. So this is a study by our colleague we've done with Shrivas, and it's about alpha band connectivity, which also again show a differentiation between unresponsive patient and minimally conscious states patient. And then we saw yesterday with Federico and Jacobo Sid that you can also use resting state EEG with other metrics using multivariate classification. And we also have in the Luminous project the team of Fabrice, who's also working on resting state connectivity. So I just show you a little bit. Then in all the study, we also assess top-down connection. This is with Melanie Wilke and Carl Friston, where we use a high-density EEG and auditory oddball paradigm and DCM analysis. And what we observe is that what is missing in unresponsive patient is actually the feedback connection from the frontal cortex back to the temporal area. Then consciousness is obviously also related to complexity, and I think this I will skip because we have seen it many times already today and yesterday, but going very shortly still. It's TMS-EEG, so we zap the brain, we zip the brain response into one number. We have the perturbational complexity index, which has a threshold of 0.31. Patients who are minimally conscious, they always show a high PCI, and patients who are minimally conscious states, most of the time they show a low PCI, but sometimes they do show some low, high complexity. And so we have 3 different measures. First one is PCI with flat, 0, because there's no brain activation, so that's usually when the patient has an anoxia. Then you have the typical slow wave, which is similar to deep sleep and anesthesia with midazolam or propofol. And then in some cases, you have high complexity. So this is probably those patients who are MCS star or who might have a better brain state than what we think. So then we can also communicate. So it's one thing to try to see if someone is conscious or not, but once they are conscious, what do we do? The point is, the next step is try to communicate with them. So at the bedside, you can say, okay, you lift up your thumb to say yes, and you close your eyes to say no. But then if it doesn't work, here it's just one case where we could use neuroimaging and fMRI active paradigm to communicate with the patient, asking if your father's name is Alexander, imagine playing tennis. And if your father's name is Thomas, imagine, and to say no, imagine to play to navigate into your house. But this, Niko will discuss this more just after me. So for treatment, there are not that many treatments currently, unfortunately. But here are still some. The first one is pharmacological, and it's with amantadine, so it's a dopaminergic agent. You take that for 6 weeks, and then in some patients, you have some recovery. And this parallels with the recovery of the frontoparietal network in this case study. Then you have the zolpidem. Zolpidem is Ambien or Stilnox, and if you take that, it's a sleeping pill. So if we take that, 20 minutes later, we sleep. But in 5% of our patients, when they take that, they wake up, but just for the time of the medication. So they will be able to walk, to talk, to communicate, or to eat. But it's really just stay for 4 hours, and then they go back to their previous states. So this is also some work we've done with Niko Schiff. And basically, we see that when they are under zolpidem, the difference is that they have a recovery of mesiofrontal cortices that's linked to motivation. So it's always useful to try on patient and see if it works. Worst case, they just sleep. And then we can also use brain stimulation, transcranial direct current stimulation. And this is tremendous work done with Thibault, Aurore Thibault, and now Alice Barra. And this is also a work that we do with the Luminous project. And so they tried to stimulate the frontal area, the precuneus, the motor, and the frontoparietal. And it seems that the best target to stimulate is, for now, the prefrontal cortex. So what have we learned so far? Well, first, consciousness is not behavioral responsiveness. An absence of proof is not a proof of absence. Then it's different from global brain function, from primary cortices. And so it seems to us, with what we've learned with post-coma patients, that it's an emergent properties of collective critical neural network dynamics that involves a frontoparietal network and thalamocortical loops with connectivity and complexity. We see that it's very hard to differentiate sometimes at the bedside if a patient is conscious or not. And so we have to be very careful when we do that. And we saw that there's a lot of misdiagnosis, so we should also use multimodal imaging when we can. That therapeutic use, so far we have not that many options, so we should really try to work more on that. And then there's lots of ethical challenges also when we work with those patients. The first one is, don't judge a book by its cover. You don't know what it's like to be a bat, but you don't know what it's like to be a post-comatose state. But we can still ask patients who are locked-in syndrome, with the locked-in syndrome, what they think. So we can do that together too. We ask them, what's the worst period of your life? You have it? That's -5. And then what's the best period of your life? That's +5. And within those last 2 weeks, where are you at? Between -5 and +5. Who's above 1? Ah, not bad. So if we look at locked-in patients, that's the answer. So you see that some of them are not very happy when they are self-assessed, but still 72% of them think that they have a good quality of life, or at least they feel good. So if you haven't seen those books, I encourage you to read them. So it's 3 locked-in patients who wrote the book with the eye blink. And if you don't like to read, this one is a movie now also. So coming back to ethics, it's of course a vulnerable population because they cannot communicate. So we need to have someone else to take decision for them. Unless you do advanced directives. You go to the city hall, at least in Belgium, and you say, if I am in that state for that long, I don't want to continue to live. So this is something that we encourage you to do, or at least to think, and the same with your relative. So first you need to know for yourself, and then you need to know what your relatives, family, or friends would like to do. And then in any case, there will be a legal representative that will need to take decision for yourself if you are in that state. And he needs to take decision based on the patient's wishes. And if he doesn't know, then it should be the best, what's best for the patient. And then in negative cases, we should also think about organ donation. And as Stephen says, there is a life after death. It's called organ donation. Or, we are also studying near-death experiences. So if you ever had that experience, so seeing a tunnel, or going out of your body, or having a blissful joy after a brain injury, but also in your sleep, or in meditation, or whatever, then you can contact my colleague Elena Cassol at this address, or Charlotte Martial, who's right there. She's also working on the subject, so please go and share your experience with them. So I would like to thank you, all of you, all our grants, Human Brain Project, obviously, but also Luminous, and the patient and their family. Thank you.
Thank you, Olivia. Very dense talk, and within the time. Questions?
Thank you for the talk, Olivia. It was really interesting. I didn't know about the zolpidem, and I was wondering if you can give it to them continuously, or is it dangerous? And second question, do you know the mechanism of action, and why is it not working in most of the subjects?
So I think it's also not working in the general population. I know some people, they take zolpidem and they are awake during all the night. So this is one. It acts on the GABA, so it's supposed to be a down agent. And the mechanisms are still not very clear. There are some hypotheses, but it's not super clear yet, and we are still doing some research about that. So we'll tell you later. No. So the patient who actually take zolpidem, they often take it 3 times a day, for instance, just before they eat. So, and there's no addictive effect, or so they can,
It's also a question we can come back to afterwards with the discussion, because I know Niko has some hypothesis in the meso circuit. Who has the mic? Yes, please.
Thank you, Olivia, for the presentation. And I want to ask you, you were saying that you can ask the locked-in people if they are in the best part of their life or the worst part of their life. How do you measure that? How do you make sure that they already understand the question, or they already can, the specificity and the sensibility of that?
Yeah, so here it was exactly the same question I asked you. So they had to imagine the worst case and the best case before the worst case before the accident, and best case, and so it's very subjective. So then they just give a number, and then we just did the average, and that's what we observed. So, and locked-in patients, they are supposed to have full cognition too, so they're supposed to understand the question like you did.
Okay, so we're assuming that they fully understand the question that you are trying to answer.
Yeah, they should have understood the question.
Thank you.
Hi, do you know if the pain matrix is preserved under general anesthesia?
I would say no, but I don't have like a reference for that.
Okay.
I don't know who has the question.
Here.
Here.
Yeah. Okay. I was just interested in if this is a conscious phenomenon or subconscious, maybe, in spite of it's in the cortex.
I guess it's the same story. If it's the whole pain matrix, then it's supposed to be a conscious phenomenon. If it's just the primary cortices, then it's supposedly not enough. But for anesthesia, I know there's also more studies now where they use isolated forearm movement technique, where, you know this technique?
I don't think so.
Okay, so they put a thing here, so then they anesthetize the person, but then the hand is not. And so then they ask the subject, squeeze my hand if you're conscious. And so sometimes they squeeze, and now they are asking that question, are you in pain?
Okay.
I don't know if we have answers yet to that, because it's an undergoing study. But so then squeeze twice if you feel pain. But the thing is, when they recover, they don't remember, never. But they actually answered that question. So.
Okay, thanks a lot. Yeah. I was asking because of animal experiments, which are often done under anesthesia.
Okay.
Thanks.
Last question.
Yeah, here is a question. We normally say a patient is made unconscious when he or she is anesthetized. So my thing is, we never lose our consciousness until you are dead. We are always conscious, only the level of consciousness changes. And I've seen when you are anesthetized, your brainwave frequency is 1 cycle per second. So we are always conscious until we are dead. Am I right?
Not sure.
Okay.
But Emery will do a talk about anesthesia just after Niko, right? So maybe he can answer.
Oh.
Thank you again, Olivia.
Yes. Okay.
Thank you.
So, for you. Our next speaker is Niko Schiff. So he's a top leader, of course, and obviously in the field of disorders of consciousness. He's a professor of neurology and neuroscience in the Vail Family Brain and Mind Research Institute at the Weill Cornell Medical College. And he also leads the McDonnell Project, which is an international project on disorders of consciousness. And today he will talk about cognitive motor dissociation after severe brain injury.
Thank you. Thanks, Olivia, and thank you for opening the talk for me. I'm going to talk today about just the component of what Olivia laid out for you of patients with cognitive motor dissociation. And the section title is Ethics, Clinical, Ethical, and Societal Aspects of Consciousness in patients. And this very unique subgroup of patients, I think, kind of puts a fine point on all of these issues, and I'll try to kind of focus that in the comments I make. I'm just going to begin with introducing the term, talk a little bit about what accruing evidence we have about the pathophysiology of patients in CMD, and then really focus on some examples of CMD subjects that we've encountered and looking at mechanisms of recovery of communication in patients like this, because some of them do recover and some of them do not. And then I'm going to focus at the end on the ethical questions and I think the societal questions that this subgroup of disorders of consciousness brings very close to us. So this is the New York version of the 2D diagram. Stephen and I have been dueling with these diagrams for a couple decades now. In this version, cognitive function runs on the x-axis and motor function runs on the y-axis. And CMD, as operationally defined for this talk, will be patients who clinically look like they're MCS minus. They don't have command following, so they're to the left here on the cognitive function line. Vegetative patients, or even patients who look like they're comatose at the bedside, who have been demonstrated either through fMRI or EEG methods to demonstrate command following. So there are examples of all of those types of things in the literature. And once you have command following, that puts you out of this gray box and then somewhere over here. Now, if there's no motor function, you really have no way of knowing whether somebody is just emerging at the boundary of MCS or further recovery, which would next be something called confusional state, where patients are able to speak, interact, but typically not oriented to their environment and don't have the sufficient resources to sustain the testing of standard neuropsychometric testing, which would assess whether there are deficits that are outside of the normative range in cognitive function or whether they've had full cognitive recovery. Locked-in patients are up here because you don't actually get the diagnosis of locked-in state unless you have consistent goal-directed movements to verify that you're locked in. Otherwise, there's an ambiguity from minimally conscious with command following to locked in if you have inconsistent goal-directed movements. And below the red line, really there's no good way at this point to assess the level of cognition of a person who shows command following on motor imagery. But we have proxies, and that's what I'm going to spend most of the next 27 minutes talking about, is what are the proxies that we do have, and what is it better to believe about these people, and ultimately, what distribution of cognitive function are we going to see in these people who are cognitive motor dissociation? I'll give you the conclusion I have in my mind so far, which is I think it's going to be a skewed distribution that's going to come closer to locked-in state, but most likely not include a lot of people who are fully cognitive, probably have a lot of people in this part of the demographic, and then maybe tail off. And I'll try to explain why that's my intuition, but we don't know. This is not something that's yet known. So the first study to really kind of make the point that this is possible was a paper by Adrian Owen in 2006, and the follow-up study was done by Martin Monti and Stephen and Adrian in the New England Journal in 2010. And this paper is very instructive for several reasons, and I'll talk about them briefly now. So in this image, which you saw before in the prior talk, a single patient who was clinically initially judged in vegetative state, and then after these results of fMRI command following were obtained. Further examination revealed some signs of minimally conscious state, so they were behaviorally reclassified. But the patients like this are very hard to identify consciousness at the bedside. Yet this patient had yes/no responses to 5 out of 6 questions that were accurate when they used motor imagery as a proxy for them to not only follow commands, but to try to communicate. Now there's a backstory, and of course Stephen knows the backstory, which is that there's only one patient who was tested in this paper for communication. And it was this patient, and part of the reason was that Martin had installed a real-time system in Liège, and when Audrey, who was running the study, saw this patient responding, he looked like a normal, which almost never happens. The signal was strong enough, and then they did this communication paradigm. Interestingly, if you look at the paper, of the 5 people who had command following responses, 4 of them were judged to be vegetative, and 1 out of 31 who showed signs of consciousness in minimally conscious state could do it. And that person was only a month off after traumatic brain injury and only had visual tracking. So already in this cohort, you could see that the people who retain this high level of capacity had very little or no motor capacity. And that has been not necessarily the theme, because there are people who obviously you can study who have MCS plus like findings and have evidence of fMRI command following, but not a lot. And I only have 25 minutes, so I'm going to focus on this, but I can answer questions about that later. So just looking at the cohort of people who are able to do fMRI command following, we looked at a group of 44 patients, 44 of whom had fMRI command following, and characterized those 4 against the rest of the cohort of 44. And Peter Forgatz, who did this study, found that there were 3 things that grouped the 4 patients who were able to do fMRI command following. One was that they had well-organized EEG architecture, so they had a normal or only mildly abnormal pattern to their wakeful EEG. They had an integrity of sleep spindles, and they had preserved cerebral metabolic activity as a group. Stephen, in a large study from his group, looked at fMRI and FDG PET and found wide preservation of FDG PET in all patients who were conscious, and that the fMRI command following was really only present in a subset of the patients, all of whom had well-preserved cerebral metabolism. And fairly recently, we published a paper in Brain looking at a larger cohort now of patients who either had fMRI or EEG command following from our lab. There are about 21 patients in this study, and this study reproduces in a larger cohort the findings of the Forgatz study. All the patients who did fMRI or EEG command following had retained normal wakeful EEG architecture, good cerebral metabolism. But nonetheless, one of the things that we found was that there was an arousal dependence, even in the high-functioning, highly responsive CMD patients, in terms of their responsiveness using the EEG measures, where we could actually make a fiducial assessment of their arousal state within each trial block of the testing. So there's a 3D part of this diagram that's emerging, and that's sort of what I laid out to suggest, which is that there's going to be an axis of cerebral integrity, which may be through fMRI, resting state, EEG, FDG PET measures, other measures, where low cerebral integrity is going to group the patients who are truly VS, MCS, and high cerebral integrity is likely to obtain for the patients who are identified as CMD. And this is and figuring out the demographic of this is undone work, but I'm going to take you through some examples of patients now to kind of give you some reasons why I think our intuition should be that we're over here on the right side of the diagram when we see people who can do this. And that, to be fair, was what Adrian Owen and his team said when they first published their first case, because as we go through, these paradigms are actually pretty non-trivial to get through. So we did a follow-up study after the Owen paper looking at 6 patients who we did command following and communication paradigms in, 3 of whom we were able to do longitudinal follow-up on, actually 4 of whom we did longitudinal follow-up on, 3 of whom had evidence evidence of command following initially. And what we found was that there was essentially a very broad dissociation. We had patients who could do fMRI command following, but didn't show evidence of communication. We had patients with fMRI command following who showed inconsistent communication, and we had one patient who was MCS and then on the retest had emerged and was fluent in speech, said that she was trying to do it, and in either case could we get command following or communication. So we already saw that there was this kind of distinction between healthy controls who you could put into a scanner and get this to be done accurately and immediately, and the patient population. I'm going to show you two cases here. So this is a first case. This is a patient who recovered communication after severe traumatic brain injury. He had a very severe diffuse axonal injury from a motor vehicle accident where his car was hit in an intersection and spun around, and this gave him radial diffuse axonal injury. He was in vegetative state for about 3 months, and then there was evidence of visual fixation that was definite in the record at 6 months. By about a year, one of his caregivers noticed that he had head movements to command and eventually established a letterboard communication system. But the patient had no system of augmentative communication provided before we studied him 3 years after his injury. So there's the first ethical and societal piece. When he came, the only person who could communicate with him was his mother, and the story, invariably, as it always is, was she had to fight every time she brought him to a hospital to explain that he was really conscious, and people wouldn't take the time to observe him carefully to demonstrate it often. When we studied him, he could do fMRI command following. We also got very robust EEG command following, but we could not turn the fMRI signal into a communication signal, which using multiple attempts, including a test-retest 5 years later. However, one of our medical students fitted him with a head mouse, and over a 5-year period, he got good enough so that he could have his own augmentative communication technology, and we actually got his assent to come in for the 5-year follow-up, and this was his email, which basically is his voice saying, "Hello, going sounds really good because I can show you what I can do now." And one of the things he could show us was that by using his head movements for several years, he suddenly, at about year 5 after his injury, developed the ability to use his thumb and then was controlling a joystick and could actually move a motorized vehicle. So he's been our benchmark because he's a perfect example of somebody who in principle we might have had an early study of fMRI command following. We don't in him, we have it in other people, but he eventually emerged and developed the ability not only to communicate, but to be tested on standard psychometric tests. So we know that he had some deficits, but could complete a full psychometric battery, 3 hours of testing, had some memory problems, had some visual constructional problems, but otherwise was in a normative range of intelligence. So that benchmarks him way to the right on the cognitive function axis. Now here's the other patient I want to focus on. We studied her extensively. This is a 22-year-old woman who had an idiopathic etiology of an occlusion of her basilar artery. This is a stent in her basilar artery that was placed acutely. You can see in the T2 weighted image, basically what should be the brainstem in this cut is cut off at the bottom of the pons. I'll show you the rest of her anatomy in a moment. She had bilateral injuries in the interlaminar thalamus, which is where we put electrodes for activation. And when you have strokes there, you end up with arousal deficits, and they can cause very broad metabolic disturbances, which I'll show you in her PET scan in a moment. She had had a vegetative state diagnosis for 2 years, although one neurologist had astutely noticed that she could occasionally track with her left eye vertically. And so she came in on our books as low-level MCS minus. But after a day of looking vegetative, we actually found for the first time that she had intermittent control of a downward eye movement. And so from that point on, it was clear she was MCS, but it was also clear, as Olivia pointed out, that there was a way to try to communicate with her. And then, and you have to understand, what's this? This is our exam. This is like how we're putting this together. Our expectation is that there might be something there. The mother brought her because she wasn't sure if there was ever going to be a sign of consciousness. From her point of view, she was totally unconscious. Seeing that she could respond with a downward eye movement, unequivocally, was a huge difference. And there's a book-length description of her case, which I'll show you at the end of the talk, and you got to bear that in mind. It's 2 years. She dragged her daughter to New York because she wanted to know something more, and then she found out she was really conscious. The day she found out, she started getting speech therapists involved, and now we're going to see what happened with her. just to give you an idea, and can somebody, I can't do it here, can you turn the video on? This is an animation. There should be a bar here, so good. So look here, this is her brainstem. You're gonna see the lesion appear in a moment. That's a normal amount of brainstem signal, and then, here we go, that's empty. That is the lesion, and it keeps going. And for the neurologists in the audience, I mean, this is something I didn't know that you could actually have an image like this and recover anything, right? Because this, now you can see, however, this image was taken 2 years after her injury. This is the first structural image we got in her, and there was no atrophy virtually in the rest of her brain. So this is really what defines CMD. It's the combination of a severe loss of motor efferents, in this case, all of the downstream fibers running through the basis pontus had been taken out, but also damage in the corticothalamic system, and in this case, bilateral injury to her central thalami. And what you can see here is broad left greater than right mesial frontal and bifrontal hypometabolism. And so this is a sort of the combination of things that go on in a patient with severe brain injury who has enough motoric disability to be the same as a locked-in patient if everything was working in the corticothalamic system, but because of the nature of these injuries, that's not what the underlying conditions are. Nonetheless, we can compare her fMRI command following to controls and to the patient I showed you before, and you can see that it was extremely robust in some of these single voxel responses, as good if not better than some of our control subjects. And the problem was that despite all this, she never quite could get a command following of her eye to turn into a reliable communication system. She got close and she got a lot better, and I'll show you in a moment how good she got. But we tracked her then from that point on for several years, serially re-imaging her and obtaining EEGs. And this report that came out about a year ago followed changes in her brain function that were associated with this inconsistent harnessing of this communication channel. So this, we've had the CRS introduced. This is the coma recovery scale. These are her values for the 4 time periods that are reported in this paper. Being able to respond to command wasn't consistent until 53 months later, so 53 months after her injury. So her first assessment was 21 months after her injury. So we had 4 assessments before she could actually do a downward eye movement consistently enough to do it 4 times confrontationally to make that scoring. This will just sort of color code and bring the whole exam up for you. Her visual function finally got up to being able to do object recognition, which is the highest level on the scale, but only on the 3rd assessment. Her best physical exam, her motor exam, was flexion withdrawal to all extremities. She had no oral motor function, and she only was able to use this eye for inconsistent communication. In other words, we could not get her to do 6 out of 6 accurate, am I pointing to the ceiling, am I pointing down, typically because the output failed. But, you know, did the output fail because she didn't know the answer, or did the output fail because it was awfully hard to get a signal through that brainstem? And arousal was not at the top of the scale because we didn't get the response on enough of the trials to meet the criteria. One more video, if we can just turn this on. This is as good as she got, and this was the result of setting up a closed-circuit CCD camera that was calibrated to her eye. And can we try to turn this video on? This was set up by an engineer at Brown, and it was turned into a game so that she could compete against herself to see how many downward eye movements. There's an audio. We're not going to bother with the audio. You can hear the computer ask her to look down. She looks down, and there's a counter here. This is 2 minutes, and she has a score of 71. She gets 90 out of 3 minutes, and this was really quite impressive when we saw it. And this was 5 years out into her recovery. But what we found during this period of time, as this eye movement turned into a inconsistent but fairly reliable channel for her, was that her brain started to change in response to language. So this is fMRI obtained from the commands from the motor imagery task I showed you before. And this is looking at all voxels that respond to language in the right hemisphere versus the left hemisphere at the first time point of fMRI, which is the second time point of the 4 in the study. Initially, interhemispheric correlation was pretty weak, if evident at all. At her second time point, you could see that there was positive correlation, but at her third time point, you can see that Broca's area has a very strong, bold response, and that right-left hemispheric synchronization was tight and obviously positively correlated. This went along with, I think, the most remarkable finding that we had in her, which was that taking an all-in omnibus FSL-driven FA across predefined cortical regions done automatically because her brain was preserved at the cortical level well enough to fit into the standard atlas, her DTI could be compared at her first and her last time point. And you see what we saw, and we quantitated it here, but you can see it by eye. There was a very clear unihemispheric cortical change in connectivity emanating from one node, and that is the parser, that's Broca's area. Okay, that's the left hemisphere expressive language area. There are also changes in her left hemisphere, and there were cross-hemispheric increases in connectivity. But it looked like there were clear structural changes emanating out of her dominant language hemisphere. And if you put this all together, we started to see a picture of the correlation of hypometabolism in the left frontal lobe filling back in, a local change in connectivity from the Broca area associated with increasing bold responses to passive language, and then synchronization of response to language stimuli going along with evidence of structural reconnection between the hemispheres. And then interestingly, she had asynchronous sleep spindles that over this period of time became synchronous and increased their activity within the standard spindle range. So we had very clear evidence that this woman who was now 23 years old at the time that this 2 years after injury series of imaging studies was done, and then 3 years later was slowly but definitely structurally reorganizing and functionally reorganizing her brain around what we infer was the attempts at using this communication channel. This also sort of shored up and extended findings we had about 10 years earlier in a famous case named Terry Wallace. This is a man who spontaneously recovered spoken language after 20 years, and he actually was testable on standard psychometrics and had low but still within the normal range values on most standard psychologic functions, and he had normal language after having not spoken for 20 years. And we had found this increase in cross-hemispheric connection in Terry, so that sort of helped us fit this picture together. The woman, I can tell you her name is Maggie Worthen. Unfortunately, she did not survive to let us try to go forward and get her a two-way communication system to work. But Joe Finns, my colleague who's a medical ethicist, framed his book about the rights of patients with disorders of consciousness around her case, and you can read all the details of her story. And for people who are interested in the societal aspects of it, I think this is a good place to start. But here's where, you know, I think this becomes sort of challenging and obvious from the point of view of where we need to go. So here are 5 patients out of 14 who've randomly walked in out of 62 people we've done these kinds of studies on in New York. So we have 14 patients who are CMD who walk through our door out of 62, not trying to find them, that's just like what we got so far. And this is a different sample of patients. Maggie's not in here, but the first patient is. And the challenge I give to you is which one of these patients with these PET scans and these fMRI responses is the guy who has normal intelligence, who's writing emails, who's moving around in a wheelchair. I give this to my lab, the people in my lab who haven't seen this come in and they go, oh, well, you know, I'm going to bet it's this one. It's like, no, you know, this person had a CRS of 9, was in vegetative state clinically with no other signs a year and a half out when we studied them. And then they say, well, if it's not that one, because they had the best pet, maybe it's this person. This person has, at the bedside, absolutely no function as a CRS of 2. But a therapist figured out that this person's tricep on one side had extra muscle tone. And so, and this is at 3.5 years into their case, figured out that they could set it up so if they held the arm up and let the person control the descent, touching the top of the head and the nose was a reliable command following system. We set up what was called an individualized behavioral assessment in this patient. We didn't have enough time for me to show you this case. It's really very, very remarkable. They were 100% with command following, but for different types of questions, they had different proportions of accuracy. For logical questions, 100%. For autobiographical questions of prior knowledge, 80%. For orientation questions about what was going on, like 50%. And this was test for test reliable within evaluations, and then 4 years later, when we readmitted the person, reassessed them. Unfortunately, 4 years later, they still had that as their communication system, which is not very good. So which one was it? It's this guy. This is the patient I showed you in the talk. So I think the ethical point here is the principle of parsimony. What's it better to believe about these 4 people? That they are really different than this person who has normal intelligence and once there was a motor channel to get them out could fully communicate, or at least if they're not just like him, they're closer to him than somebody who's not conscious. I think it's most likely that they're closer to him. And actually, we now have a little bit more data. So this patient, at 3.5 years after injury, emerged. They developed gestural communication. And now, at 5 years, and I just left New York, we were doing our 4th study of this person, they developed the ability to point and touch an iPad and are typing. And one of the things this person said to their last evaluation with their own physicians was, I wanted to be a pediatrician just like you, and I'm going to be a doctor. So, this is what it looks like. And I'm not showing, this is 5 patients. I'm not showing you the other 9 that we've randomly acquired so far, but they weigh on us because we're not really doing anything for these patients. So one of the things we are going to be able to do now, and this is the result of this very generous consortium that the McDonald Foundation gave us money for, and includes Stephen and his team in Liège and groups around the world, including the Paris group, which is very well represented here at the meeting. Lionel and Stan DeHaan were the PIs on the Paris site. We have collected 307 patients who just are anecdotal convenience samples, but across all of these centers, and we are going to have a number of percentage to compare. I don't know what the number is, but the number is going to be big enough that it matters. And it's going to be big enough to say there are lots of these people everywhere in the world, and if anything, this work should at least say, go find out who anybody is and label them properly, because these people, they should be identified, and then we should start efforts to systematically try to engage people who can redevelop a communication channel, because clearly if you get the harnessing of one, things can change, and that's what that paper shows. Now, it's a little better than that. I don't have to go through this too much. I think, I said that, basically these patients look like they're in a separate category. Hopefully I've convinced you that that's possible. I think they're most likely closer to locked in the majority of cases, but we don't know what the distribution is. But I think it's clear that we need to urgently figure out who they are and try to reestablish communication if we can in any of these people. There are different patterns that are going to be more or less likely to have this kind of problem. You can anticipate cohorts of patients who are at greater risk. But it's a fundamentally different thing than locked-in, because locked-in patients, by definition, just have damage within the motor efferent systems. And the role of altered mesocircuit function I really didn't get into, but I think that plays a key role here, and is probably the return of activation in this anterior forebrain mesocircuit when it's possible to recruit Broca's area. that may be driving this. And this is sort of the hypothesis that Dan Thengan and I put in his paper in Science, Translational Medicine, that I just went through for you. And it came up yesterday, and so I put this on the slide today because this is sort of what we've been thinking, that the merge function, which is largely thought to emanate from Broca's area, may be what's driving these structural and functional reorganizations, and why there's so much broad change that you see happening late in this patient. There's one other piece, which I'm not going to get into, but I can tell you we have generalized this, and we have evidence that this does occur in other patients, and it's going to be under review again, and hopefully out soon. And I think that's going to be very helpful in pushing this particular part of the story forward. So I'm just going to thank the people in my lab, particularly Dan Thengan, whose work I just went through in great detail, and our funders. And I got 1 second.
Thank you very much. Questions? David.
Yeah, thanks. I was very interested by what you said about command following being so difficult, even as a criterion for cognition. So in these MTS patients, you only had a very small number who were able to do the fMRI command following, even presumably, though they all have some significant cognitive functions. I'm just wondering what happens when we extend this to the unresponsive patients. You get some significant number of unresponsive patients who can do the fMRI command following, presumably extending the reasoning, since that's so demanding. And one might even expect that there'd be a larger body of the unresponsive patients who can't do fMRI command following, but who nonetheless have cognition. And I'm wondering, is there anything to rule that out? And is there anything on the horizon that might be available for using fMRI or other methods to detect cognition in the absence of command following?
So let me take it in pieces. So I think the command following that's difficult, of course, is and I sort of lost the thread of that to point it out. To do these fMRI studies and to do motor imagery, it's 8 blocks of 30 seconds of imagine yourself doing something. It's not like, show me a thumbs up, right? You're sitting there for 25 minutes doing a structured paradigm in an MRI scan to get to the statistical criterion to say there's a result there. In general, the patients who show less motor activity have shown a higher proportion of being picked up by this technique, and my point is that that's probably because when you have that much preserved function, you otherwise know about it unless there's a lot of impairment in motoric efference and being able to communicate your awareness and your being present otherwise. That said, the sensitivity is terrible, right? Because, and this is what Stephen's paper showed, you can't use the fMRI to go screen people, whether they're responding at all or not at all or a little bit. There are other tools that are showing, with what the Paris group has shown in terms of at least showing levels of awareness between vegetative and MCS would be the first step. There's some other tools coming along that look like they might correlate with this, that would be simpler and cheaper and easier to do as a first screening step. And I think that's kind of what's going to have to happen.
Can I just put it by asking, is there anything to rule out that, say, half of the patients who are unresponsive nonetheless have some cognitive function,
yes,
which is not showing up?
So one of the things that I think is not obvious to people who don't do this for their day job is that the demographic of people who are in vegetative state, because again, typically, if you're in vegetative state, there's a reason and there's an etiology and there are severity measures, whether it's trauma or hypoxia or something else, that sort of first, before you do any imaging, can kind of tell you, gee, did this person have a very serious injury or lose oxygen for a really long period of time? Does it make sense that they're still in vegetative state? And then, there's going to be some discordance there. You can handle those people separately. And you take the people who've had the reasons to have a lot of brain injury and are still in vegetative state. Most of them don't look anything like the patients I'm describing in terms of the basics, like their EEG architecture for sleep and wake and all these other things. And that's,
Olaf?
Okay, yeah, wonderful talk, thank you. The 3 examples you gave, they seemed very young, in their 20s, I think.
Yes.
So, you know, do you have any data of such wonderful recoveries, you know, for 60 plus?
Yes.
In workplace age and children, I think in particular, concerning this idea of broca as being important.
The answer
more
is-
plasticity. So that's question one. Question two, very brief, what do you think about neuroprosthetic approaches, invasive approaches? I think you mentioned the group at Brown University with implanted electrodes to
Very simple to answer, yes and yes. So but I'm going to unpack it. One of the cases that we have that we've studied longitudinally in the larger cohort is a woman with hypoxic injury who recovered fluent language between age 58 and 60. And so that pretty much is a good endpoint for the first one. I've been working with Lee Hochberg's group, and you know, it's going to take 5 or 10 years, but I think that is a direction that we want to go in. In fact, I just gave a talk last week on that, eventually doing invasive prosthetics.
What does it mean about plasticity in that sense? I mean, do you have examples in children, I guess? Do you have any children cases?
So we have cases that were injured as children who we were able to study because they turned 18 by the time that we saw them. And we have a case like that. We have a CMD case like that. Yes.
Technology. The question about brain-computer interface, for example.
That's what I'm sorry. That's what my answer was before. That Lee Hochberg and I are working toward bringing that together. We think it's going to take 5 or 10 years. It's really there are a lot of challenges. But Maggie, the case that I showed you, we had done all the work for her, and she was brain gate enabled. We found that she had single trial decoding from the hand area, and had she lived, she could have been the first one. Very frustrating.
Yes. I know there's many questions, but we will keep them for the discussion afterwards and have one short final question.
Very short. Thank you very much. I just want to say whether it came out, but whether you are, in a sense, take into consideration that these kind of results that are coming from your group and other groups on the longitudinal study are bringing another major ethical issue, is that in many countries, after 12 months of vegetative state, patients are interrupted. And these kind of results that deny neural plasticity, what you're saying, in a sense, they are behind this study, but I think that we as international science community have the responsibility to come out more and more with the issue that 12 months is not enough, as much as 6 months of rehabilitation for most of European countries is not enough.
So a couple reactions to that. One, of course, is that I don't know that any of these patients, if we looked at them carefully, say at 6 months, wouldn't have already revealed that they were distinct. My guess is that they would have. That said, everybody has to start evaluating patients after they leave the hospital, and in our country or anywhere else, no one's getting paid to do that. So we really need to do this. That's right. Like if you have a family member, you really want to have a better answer, because if they're MCS 3 months out, they have at least a 50% chance of having a good outcome at a year if it's trauma, right? And yeah, it's a mess.
Okay, thank you so much, Niko. I should, of course, for our European friends, stress here that when Niko says vegetative, he actually means unresponsive, right? So, we move on, and we're extremely happy to have world-leading expert on pharmacological loss of consciousness, anesthesia, with Emery Brown from Mass General and MIT. You're all set, please.
Great, thank you. So, thanks to Johan and Marcello for inviting me. So I'm going to talk about anesthesia, just as Stephen said. And so I'm going to talk about it in terms of altered states of arousal. I want to mention the folks that I've had the good fortune to work with to begin with. So Nancy Coppell at Boston University, Patrick Purdon, who's my engineering colleague at MGH, neuroscientist, Ahmad Eskandar, who's a neurosurgeon at MGH, who's now moved to Einstein, Sid Cash, who's a neurologist, Laura Lewis, who was my PhD student, now just joined the faculty at Boston University, Marus Naranjo, who's my colleague, anesthesiologist down in Mérida in Mexico, Cara Pavon, who's one of our research clinical coordinators, and Seung Keju, who's an anesthesiologist at Mass General Hospital. So I'm going to cover 3 things. I'm going to talk about, I'm going to pick up on sort of kind of the clinical view of what Sean was mentioning earlier, that is this idea of sort of generating slow waves. And I think he did a great job for me in sort of setting up like the mechanistic framework that I'm going to go over. And what I want to show you is what that translates to in terms of people. I'm going to talk about multimodal anesthesia because I'm going to use the idea from the first part to sort of suggest how you can take the same drugs that we use on an everyday basis, give them in a different configuration, and achieve the state in a way which I would argue is better for the patients. And the final thing I want to talk about is waking the brain up from anesthesia, right? So these slow delta oscillations. So I'm just going to go back to something that historically, so this is just a kind of a cartoon version of experiments that Frederick Breme did back in 1935, in which he did 2 transections. They weren't of the human brain, but they were with cat brains. And he did a transection at A, and he measured so he's separating the spinal cord from the brainstem and the brain, and he called this the encephale isolé. And he looked at he's measuring the EEG, and he sees what looks like an awake EEG. And then he does another experiment in which he separates the brain stem and cord from the brain, the cerebrum, and he called that the cerveau isolé. And he saw these sort of slow delta oscillations. And that's one of the first points that gave us this idea. There was something in that part of the brain between A and B that had to do with arousal or keeping the brain awake. So I'm just going to apply this principle here now. So I want to show you a little video. I like to use this video because it illustrates just how profound anesthesia is, how profound it is, how quick it is, and also how strong the signal is coming from the brain, even if it's just surface EEG, all right? So this is in our operating rooms, you can put EEG on all your patients. So there are 4 leads, 2 here, 2 on the left, 2 on the right, and the ground and the reference are in the middle. And this is a lady who's 60 years old. She's going to have thyroid surgery. She weighs about 80 kilograms. I'm going to do something very standard. I'm going to give her a bolus dose of propofol, about 150 milligrams. Just push it in. This isn't edited. This is in real time. So I'll just play it. I'll just talk through the various parts of it. So the first thing you're going to see is, so those are eye blinks. You're going to see this get very noisy. And it's going to get very noisy because if you inject propofol into a small vein like the one on the back of my hand, it burns like crazy. And so she's tensing up like this. In fact, Michael Jackson knew this, and he used to say, "Can you give me my numbing medicine before you give me my milk?" Propofol looks like milk. That's what he was trying to use to sleep. So see how noisy it is? So that's actually going to be good for pedagogical purposes here, because watch what happens in just a second. You're going to be able to see very clearly when the drug takes over. All right, just about another 4 seconds here. So watch this. Right here, you're going to see, boom. See those beta oscillations? Right? And now they're going to go into slow oscillations. And if you talk to her now, she's out. She's unresponsive. And these are going to convert into burst suppression. She's going to go flat, and then burst, and then flat, and then basically burst. All right, she's out. All right? So what did I just show you? So this is her awake. All right? And the size of the oscillations, the size of the EEG matters quite a bit. All right? So she went from A here down to B, the state of sedation. These very regular beta oscillations. And so these are the sorts of oscillations you see if you just take a low dose of midazolam or one of the sleeping agents. You actually get beta oscillations. And if you think of the sleeping agents as sort of weak anesthetics, you're probably a better approximation as to what they are, as opposed to thinking of them as really inducing sleep, right? And then she went a bit further. She went into this very slow oscillation state. She actually passed through this. She didn't even see this occur. She went right into these sort of state of very, very large slow oscillations. And this is probably when the drug is starting to have a very profound effect. It's already acting throughout the whole central nervous system, but in this case, probably profoundly on the brainstem. Then you saw her go into burst suppression here at F, and then she was isoelectric. She's isoelectric between the bursts, all right? And you didn't even see this state, the alpha and slow oscillations. And so I won't talk much about the alpha oscillations here, maybe just in passing. And we didn't even see the paradoxical excitation state in her. Now, the main point that I want to make is the following. The size of these oscillations matter quite a bit. You see how large they got? They went from something which is about 5 microvolts down to up to something which is between 20 to 50 microvolts. In kids, these oscillations will be as large as 1,000 microvolts. They're highly structured. So what that's telling you, to actually do that, if you're actually driving these extracellular currents, what you're seeing is the drugs taking over and systematically controlling these extracellular currents in a very regular way. As long as the drug is there, you're going to have this sort of profound effect. And what's really interesting about this is I would argue this is the highest signal-to-noise situation for which the EEG is used, whether you're talking about looking at patients in coma, diagnosing or sort of defining sleep, meditation, cognitive tasks. This is the highest signal-to-noise ratio there is. The ironic part of it is that we don't typically use it regularly, as we should in the operating room, to infer the states of patients under anesthesia. All right? So I'm going to go through the various drugs and just sort of show you what their slow oscillations look like. All right? Because even though they all produce slow oscillations, the slow oscillations are quite different in character. So just because you see a slow oscillation doesn't mean the brain is in the same state or level of unconscious or altered arousal. So these are data from a study that we did with, that's why I mentioned my neurosurgery colleagues. So just like I'm sure in many of your hospitals, you have patients who come for epilepsy surgery, they get electrodes implanted, they stay in the hospital for a period of 5 to 7 days off of medications. They are allowed to seize off of medications. Once they've seized enough, they come back to the operating room. They have an explantation where you remove the electrodes, and then in another surgery, they'll actually resect the area which they think is the epileptic focus. And so what Laura did, Laura Lewis, was just go in and record in the patients the second time that they had, when they had the electrodes implanted. And so it's a free natural experiment. You get to see what happens to neurons in the human brain when someone becomes unconscious. So if you look over here on the left side, so these color-coded field potentials correspond to, they're recorded at the sites on the temporal lobe here as indicated in the diagram. And this is the spiking activity. So basically, you have sort of asynchronous or field potentials, the patient's awake, and you see that the neurons can spike pretty much wherever they want to. So if you look over here, once the person became unconscious, you see these very large slow oscillations. They're not subtle. But the other thing, which is very compelling, is that if you look at where, so these are neurons that were recorded, or a neuron that's recorded close to this site here, the red site. And you can see it only spikes at a very limited phase window, right? And before we even did this, we knew from EEG recordings that the slow oscillations across the cortex under propofol are actually not coherent at all. They're actually quite disconnected, all right? So I mentioned that little factoid because now if you look at these field potentials, they're disconnected exactly the same way, and neurons can only spike in limited phase windows. It's going to be very, very difficult to communicate. And one of the things we've been talking about is what kind of neurophysiologic evidence might you have that you could take to the operating room and sort of have a good sense that someone is unconscious. And I would argue this is probably some of the most compelling information that at least we've been able to accrue. All right? So that's propofol. All right? And so here's what it would look like in the operating room. You see there's a very strong alpha oscillation there too, the 10 hertz oscillation you can see in the spectrogram there. And then there's the slow and delta oscillation. So my statement is, and so it looks like they come on, you can see they're there very much at the same time here, if you look right here. If you're looking right here. And what's interesting is, as I said, the slow oscillation or delta oscillation is actually quite incoherent across the head, whereas the alpha oscillation is totally coherent. The coherence in the alpha range is about 0.8, 0.9, but it's all frontal. All right, so there's a whole different spatial dynamic between the alpha oscillation and the slow oscillation. All right, and then we can point to very good ideas about why this would occur because of all the GABAergic targets. Propofol works by enhancing GABAergic inhibition. And the targets going from the cortex, the thalamus, the brainstem, even down to the spinal cord, it's a setup for propofol. And in particular, we think the alpha oscillations represent a thalamocortical piece that is highly coherent. There's a lot of modeling evidence and actually experimental evidence for that. And the slow oscillations probably represent not only the hyperpolarization induced by the inhibitory interneurons in the cortex, but also this decrease in excitatory inputs coming from the brainstem, because one of the primary targets of the propofol is probably those GABAergic projections which come out from the preoptic area of the hypothalamus and hit the brainstem. So it's basically turning off these excitatory inputs going to cortex, right? Let's pick another drug. So dexmedetomidine. Dexmedetomidine works by enhancing alpha, it's an alpha-2 adrenergic agonist, all right? So it acts presynaptically, and it stops the release of norepinephrine, wherever norepinephrine goes. So if you just trace out, even before you look at anything here, if you just trace out where these projections would come, they'd come from the locus ceruleus here, they would go up to basal forebrain, they go to cortex diffusely, they also go to central thalamus, and they also go to the preoptic area of the hypothalamus, all right? So again, a good candidate for producing a slow oscillation, just applying like Bremé's principle, given what you see. And so I've put two schema up here. So this is a light dose of dexmedetomidine. You're giving the patient a light infusion. We won't go into the details of what that really means, but you're not giving them much. When that happens, you actually see spindle activity. You see the spindles right here. If you look at it in the time domain, you can see them. Spindles in addition to slow oscillation. Oops. Spindles here again. And so this is what it looks like in the frequency domain. This is different from those alpha oscillations I was just showing you for propofol. The structure is quite different. They're much more intermittent. What's interesting is when you increase, just like in sleep, when you go to a more profound state of actual natural sleep, when you give more dexmedetomidine and you have deeper sedation, the spindles disappear, and all you have are just slow oscillations, all right? And again, the reasons for this makes a lot of sense, but a different mechanism probably from the propofol. And the one thing that we know here is that these slow oscillations, so this patient here, who's even on this sort of slow oscillations under dexmedetomidine, you shake him or her, they'll come to, they'll wake up. They're not profoundly sedated in general. That's not all the ways necessarily true, but let's say for the sake of this discussion, that's the case. That wouldn't happen with the propofol, right? And this is my favorite of all, this nitrous oxide. I didn't know this, and I discovered this one day in the operating room. I was doing a case with a chief resident, and one of the things that we do clinically and under anesthesia very often is switch to nitrous oxide at the end of the case, because nitrous oxide is eliminated very quickly, and it makes it easier to wake someone up because you get the heavier gases off, like sevoflurane, off. Sevoflurane is an ether, by the way. We still use ethers. And so here's what happens. So you look over here, and it's sort of marked out here in the time. So in this case, they're on isoflurane and sevoflurane. It doesn't really matter. Either one is fine. And then you turn on nitrous oxide, and nothing happens really. Maybe you see the spectrogram changing here. So this is a very typical pattern for isoflurane or one of the ethers for under anesthesia. And then over here it looks like it's changing a little bit. Then all of a sudden, you drop to these very, very large, low-frequency, slow oscillations. And I wasn't aware of this. I'd never seen this before. These oscillations are amazingly large. And in fact, I'll come back to the mechanism. I just wanted to show you what they look like on the monitor. It looks like they're like hand-drawn. When you see them, this brain state here is like wild. And it's incredible because they don't last. They're totally transient. They last for only about 6 minutes, sort of on average. It can be as short as about 2 minutes or as long as about 12 minutes. Then they evolve into a high-frequency oscillation. You can see that back here. So if you look right here, you see this is the whole time course. Here's the profound slow oscillation. Then they broke up, and they went into these like higher frequency oscillations. If you look up in the textbooks, this is what they tell you that nitrous oxide does, but it's not like that at all. And in fact, so you can see if you check the date, this is just from about 3 days ago. I was in the operating room, and we had a bit of a sort of a mini emergency. We're taking care of this woman who's a 30-year-old drug addict. She's about to have surgery on her shoulder as well as on her leg. She had these very nasty wounds from doing all these sort of shooting up. And so remember, propofol burns when you inject it. So the propofol started burning. She does like this, and the IV pops out. And so now we have a patient who's partially anesthetized with a no IV. So this is not a cool situation to be in. So we started masking her with sevoflurane, and then I was with a very experienced nurse, so she turns on nitrous oxide. And within about 10 to 15 seconds, you got these slow oscillations just like this. In the middle of the emergency, I said, I know it's an emergency, but I got to take a picture of this. So I took a picture. Okay, let's go back and take care of the emergency. All right. But you can see them. They're enormous. All right. And then she she went out. And it was enough for us to then just put another intravenous line in and then sort of go and take care of her, all right? So what might be happening here? Now, don't know this, right? But again, just applying this idea from Breme, if nitrous oxide is working on these targets, which are NMDA, there are a number of great targets in the brainstem here, like the parabrachial projection into central thalamus and also to the basal forebrain, right? So just leaving with an idea, something we have to investigate. And one of the problems is you can't just give someone 70% nitrous oxide just starting with that because it's so nauseating. People will vomit. So you have to have a way to move into it. So that was why we were able to discover this quite by accident, because they were on a drug other than nitrous oxide when we first did it. And I'll just end with ketamine here. So ketamine produces these very high frequency oscillations at low doses. And this has been known for a while because at low doses, what it does is it actually affects preferentially the NMDA receptors on GABAergic interneurons. So it takes out the interneurons. The pyramidal neurons are free to do whatever they want to do, all right? Then when you push to a higher dose, they actually take out the pyramidal neurons as well. And you have this very interesting pattern of not just slow oscillations by themselves, but you have this pattern I'm showing you here. It actually is this, it's a high frequency oscillation, then a slow oscillation. High frequency oscillation, then a slow oscillation. The high frequency oscillation is in the gamma range. And then there's a period between this segment here. There's a period between this segment here and here, which is about 6 to 10 seconds. So it's 6 to 10 seconds, just like this. 6 to 10 seconds, all right? It's very, very regular. This person's unconscious in the sense that I could do surgery on him. In other words, if you were going to someplace, a remote place, as an anesthesiologist, and you could only take one drug with you, you would take ketamine with you because you could use it for sedation, but you could use it as a total anesthetic, all right? So this is what we see. So these slow oscillations are everywhere. And I just want to point out 3 other cases. The other time we see very profound slow oscillations is in young kids 0 to 3 months of age, on, let's say, like on like sevoflurane or propofol, just have slow oscillations. And we think that this probably represents sort of the brain being very young still, and particularly like the thalamocortical connections not being as intact as you might imagine, all right? That changes at 4 to 6 months. At 4 months, you actually see the alpha oscillations appear along with the slow oscillations. Another case is particularly in older patients. In older patients, even if they're quite cognitively intact and no evidence of any sorts of problems, under anesthesia, very often all you see are just profound slow oscillations, right? They may have a hint of an alpha oscillation. Sometimes it's really interesting. You'll see it there at the beginning and it'll fade out by the end of the case. So it's like you're almost watching their brain sort of age kind of in front of you. And then also sick brains or sick people. People who are, particularly if they have a rip-roaring infection, and if you put the EEG on them, I'm sure if, those of you who work in the ICU have probably seen this, their brains are basically turned off. They're essentially auto-anesthetized. And it kind of makes sense because the inflammatory mediators actually inactivate the arousal systems. It's a physiologic mechanism. IL-6 binds to the dorsal raphe and shuts it down as a way to help you rest up when you're sick. So the fact that you have an overwhelming infection, this would be quite soporific, makes a lot of sense. All right. So let me just talk about multimodal anesthesia. So this is a definition that Niko and I, along with Ralph Leidig, worked out for anesthesia and wrote about it in the New England Journal about 8 years ago. And I've changed it. I started a bit because we said analgesia initially. So it's drug-induced reversible state. There's the antinociception, so you're blocking pain processing and perception. You're unconscious, amnesia, and akinesia. Before we said analgesia, but I underscore the antinosis. I put that in there to underscore the fact that this is happening at a time where ideally you're unconscious, so you can still have nociceptive responses. Your body can still respond to pain even though you wouldn't perceive it. And stability and control of the physiologic systems, all right? So the way we typically do anesthesia now is we give combinations of drugs. one from the various categories. And what we've learned over time is that this allows you to have most of the good effects with fewer of the bad effects, all right, side effects, all right? But I want to suggest a different strategy, which is it's going to be balanced, but I'm going to start and pick my drugs a different way. I'm going to pick them in a principled way, I would argue. You need anesthesia because it hurts. It's not because you need to be unconscious, because there are a lot of surgeries which are done with patients just sedated or completely awake. So what we should do is attack the pain pathways at multiple locations and use that to enhance antinociception. Now what that does is that's going to give you some measure of sedation. All right, with that measure of sedation, it's actually going to decrease the amount of the drugs that you need in order to keep the person unconscious. So hypnotic is a term that we in anesthesiology use to mean a drug which keeps you unconscious, all right? To do this, you have to monitor arousal, so you can't do this blindly. You have to have something which you're tracking the level of arousal, in this case the EEG, and some measure of antinociception, and that's going to be changed in heart rate and blood pressure. We don't have a good monitor for that at the moment, and you should continue to do this post-operatively. So I just want to show you a couple cases of this. So this is a lady I took care of just back in the 1st of May. So she's 77 years old, and they're going to do a major operation on her. They're going to take out both kidneys, they're going to take out her bladder, and they're going to reconstruct the bladder in what's called an ileal loop. So she's about 80 kilograms, 81 kilograms. She's about 1.5 meters. And so the anesthesia that I gave her is just dexmedetomidine, lidocaine, and for propofol, I have an infusion of 30 mics per kilo per minute. Now, those numbers may not mean anything to you if you're not an anesthesiologist, but the typical dose for a case like this, just guesstimating, would probably be like 100 mics per kilo per minute, just to give you some idea, all right? And so this is the case, and so with all the position changes, her vital signs are moving all around. As we put her in one position, move her this way for one kidney, move her this way for the other kidney. Now she's up, so that's why it looks like it's sort of moving all around, but we had no trouble controlling her blood pressure, heart rate, that sort of thing during the case. This is one I want to show you. This is the EEG. So if you look here, the whole time, this woman is basically in burst suppression. I'm giving her next to no propofol to keep her unconscious, but she is most of the time in burst suppression. So what's happening? She's an older patient. Remember I said you're going to be generating slow oscillations either way because the brain is older, and this is where it shows up functionally. And the other drugs are actually acting to help hyperpolarize probably the cortex and the thalamus, so the amount of propofol you need to get to the same state is actually less. And that's what's happening here. In fact, it may be a little bit of a challenge to see. It turns out she's been in burst suppression like this for the last almost hour. So I didn't do it with her, but in a subsequent case like this, I actually turned the propofol off for a half hour, just turned it off, right? And the person just basically stayed there in burst suppression. It just shows you how profoundly inactivated the brains of older people are. And I would argue that most older patients, we're overdosing them. And we could change our strategies quite a bit. And just to show you that this is also true for younger patients, here's a guy who's 32, all right? He has this incarcerated hernia and the same sort of thing. So giving this guy 150 to 175 mics per kilo per minute of propofol would be very typical. I'm giving him 75. He's getting dexmedetomidine and also remifentanil. And his vital signs are like this. They're like rock stable during the whole case. And then if you look here at his EEG, he just has these very, very stable alpha oscillations and slow oscillations, again, being generated at a much lower dose of propofol. That would, in principle, that would barely sedate him if you were just giving it to him, giving him that amount of propofol by itself. All right, and so here's what we're doing. You're using multiple drugs, opioids, ketamine, let's say dexmedetomidine, or even the anti-inflammatory drugs to hit the pain pathways at multiple locations. That decreases arousal, so the amount of propofol you need to keep them unconscious is much less. As a consequence, these patients actually wake up far quicker, and I would argue it's going to be one of the things we're going to need to do so we have less brain dysfunction after anesthesia. All right, so reanimation. So we don't give you something to turn your brain back on after anesthesia. What we do is we just passively let the drugs wear off and see how you see what happens. And so it's the art of it. You know, you time it based on where you see the surgeon is in the operation. So this is work done by my colleague Ken Soul. And these are rat volunteers that come over to his laboratory. And so here's one of them who has a propofol infusion in his tail vein there. And he has a stimulating electrode in his ventral tegmental area. So he's anesthetized with propofol. He's just there. All right? And so Ken is going to turn the stimulation on. Actually, watch right here. Watch what happens first. Look what happens when he turns the stimulation on. The first thing you see, breathe like crazy. Now, we didn't turn the propofol off. He's still getting propofol. Says, look, I'm out of here. All right, cool. All right, now, so is he conscious, though? Can he function? All right, so what Ken did was another study. So he trained the rats. He trained the rats to do a task. So the rat goes here, hits the correct light, turns around, and gets a food reward. So he trains him on that task before he anesthetizes him. So now he anesthetizes him. He wakes him up. He wakes him up by stimulating his brain, but leaving the anesthesia on. The animal wakes up, is going to go and perform the task, and then Ken's going to turn the stimulation off, and when he turns the stimulation off, the animal's going to go back out, all right? He's only awake because we're stimulating his VTA, all right? So here, I'll play this for you. So there's the rat. There's no stimulation on. So now, the food box is over here to my left. So he's going to, when the stimulation comes on, he's going to go there first and look for a reward. So Ken turns the stimulation on. The anesthesia is still on. He looks for a food reward. There's no free lunch even in this time. So he has to go, so he hits the correct light. He turns around, he gets his food reward, right? And Ken, just for the sake of it, changes the stimulation to 20 hertz as opposed to, turns around again, right? Hits the correct light. A little wobbly, but I mean, he's functioning. He's doing a task, right? And so now he turns around again. I think he gets this one wrong. So the light comes on and tells me he gets it wrong, so he's not going to get a reward. So now he's going to do this again. So the lights come up. Now Ken turns the stimulation off. And he's out. The anesthesia takes over. All right? So he was only functioning because his brain was being stimulated there. All right, so what's happening here? So we've done this with Ritalin, and in fact, Ken has a clinical trial going on now in patients testing out this idea in a phase 2 clinical trial that giving Ritalin as a way to wake patients up from anesthesia may be a good thing, all right? But what we were doing here was stimulating electrically here. We've also done it optogenetically, the ventral tegmental area. And, you know, this is the mesocortical pathway running from the midbrain up to the cortex, talked about most commonly for reward, but it's also very important for cognition. I mean, the folks who self-administer these stimulant drugs like Ritalin or Adderall in the United States because they're in high-stress jobs are basically doing this. They're activating this pathway, and some folks feel like they have to do this every day or they can't be on their game, and they will tell you that, you know, their minds are sharper when this is happening. So as a thought, if we've messed your mind up, we've had you sit in states with these pathologic oscillations for 4 to 6 hours during an operation, maybe we should turn your brain back on afterwards, and this might be a way of doing it. All right, so this is what I've just shown you. I've shown you these anesthesia-induced slow oscillations, and we think that mechanistically they're working by helping to hyperpolarize these upper structures like the thalamus and the cortex, and this is probably the common feature of the anesthetics, but they're different states. They're not the same state because the mechanisms through which the drugs do it are different. I showed you something about a way to reconfigure the drugs, putting an emphasis on anti-nociception, and then arguing from the first point that why that might be more effective. And as I just showed you, maybe turning the brain back on after anesthesia may be a way to help recover consciousness faster, but also prevent or help reduce the incidence of cognitive dysfunction. Depending upon what study you look at, 20 to 40% of patients over the age of 60 will have brain dysfunction after anesthesia. It can be anything from simple delirium, which may last for a few hours, to brain dysfunction for several months afterwards. So I'll stop there. Thank you.
Thank you very much for your great talk. So just before questions, the speakers should stay after the question for a photo. Questions?
Yeah, here. It was a very interesting talk. So I was intrigued by your VTA stimulation result, and I was trying to link it to some of the previous talks where they suggested to stimulate the thalamus to wake up people who are in coma. So, I mean, you could ask this question two ways. So have you looked at those regions that are being stimulated in those comatose patients? And the other way around, have people who are studying comatose patients have considered the VTA stimulation?
Well, I'll let the second question go to my guys here, since, but yes. So here's what happens. So we've done a number of different areas. We've done central thalamus, we've done VTA, we've done parabrachial nukes. It turns out waking up is not that hard, because remember, we have kind of a favorable situation. The circuits are intact, okay? So the anesthetic level drops enough. If it's too profound, it's just not going to work. If someone's flatline and in burst suppression, it won't work. But when they're about to come to, if you stimulate here, right, and all you need is a major arousal pathway, right? So, but the key thing is, it's a little misleading the way I show it. The stimulation probably activates the cortex, but now you get the descending projections which activate, and now you get a loop which occurs, and that's probably very easy to initiate from any one of those situations. So anesthesia is the easy thing because these areas are intact, all right? But it does suggest that, you know, if looking at other areas, you know, might be very, very feasible for, you know, for therapeutic patients who are in states of coma.
Thanks.
Yeah, very nice. I had two questions. So if we look at all the differences between the anesthetics that you showed, is there anything you could say about how anesthesia is still distinct from slow wave sleep, or what would distinguish that? The other question is to what extent you think the VTA or dopamine neuron activations are comparable in a way to the treatment of post-encephalitic patients with L-DOPA, also reported as waking up, but whether this is motor activation or general wakefulness is also a question.
That's a good question. So let me just take the first one about the slow wave sleep. So again, the slow waves that you typically see in anesthesia so they're different mechanisms. The one which is closest to slow wave sleep is this one. All right? So the ones which come from dexmedetomidine, because you spindle at low doses just like you have spindles in slow waves, that's like non-REM stage 2. And then at the higher doses, you have just slow waves, that's just like non-REM 3. All right? This, let's say like something like nitrous oxide, this is freaky. That's all I have to say. That's weird. It is wild when you see it. It's like all of a sudden a tsunami hits you. These oscillations are enormous, and so we've actually measured the sleep oscillations like in those patients that had electrodes implanted. Their sleep slow waves relative to like their propofol slow waves. The propofol slow waves are, let's say, 50% larger, and I would think Dex probably falls somewhere in the middle. They're larger than the slow waves that you get like from sleep. And so with the other case, the last one you asked me, I don't know. I honestly don't know.
Right. Okay. Thank you.
Thank you. Very nice presentation. When you say that you can keep the anesthesia on in the rat and still stimulate VTA, and the animal is apparently totally functional and awake, have you considered to test if the animal remembers that? For instance, in a reinforcement program, that the animal has to do two similar responses to get the reinforcement, and test it in the moment when the animal has to do the first one, and then test if the animal remembers that.
Yeah, no, it's a good question. So, but let me just put it in a context. So in the field of anesthesiology, showing that an animal is awake, all you have to do is show that he turns over. All right, so the fact that we actually have him doing a behavioral task is like a huge move forward, like in the field, because that's not typical. We just left the anesthesia on just for the sake of this, just showing that you can probably do this with the arousal system. You can probably move it up and move it down, all right? So we could have him execute a task while he was under that state and see if he retained it. But the only reason I wouldn't rush and do that is that this is not a natural state. That was just for the sake of illustration. What I would just want to wake him up and show that he could be totally functional. And what I'm showing is he's partially functional, even with anesthesia still working. So the suggestion would be if you let the anesthesia wear off, he'd probably be quite functional.
One more question.
Well, thank you for a wonderful talk. Mm-hmm. So you showed us about, let's say, 7 different ways in which you can be effective in inducing an unconscious state on your patients. Mm-hmm. But that would suggest that there's either a very heterogeneous set of processes and mechanisms underlying states of consciousness, or that there are some underlying principles that they all tap into. So if you would have to choose, let's say, the 3 dominant principles underlying these 7 different schemes, what would these 3 principles be?
So this is where I have to draw the distinction between what I do and what I think what all my other distinguished colleagues do. So I work on unconsciousness, all right? So I've shown you like 7 different ways to make you unconscious, all right? And so by that, so the analogy is like, we all have cell phones, right? I have no idea how that works. However, I know if I take the battery out, it won't work. If I put the battery back in, it will work. So I'm in here just pulling the battery out and putting it back in. That's basically what I'm doing at this point, all right? Now, if I do that, if I do a good enough job, then you will eventually learn that, oh, the battery controls the electrical system, all right? So, I mean, to put this in the context, I mean, that's really what we're doing here. You know, we're trying to study these kind of natural chemical lesions that we give every day. 250 million people a year get anesthesia, right? 60,000 people a day in the United States get anesthesia. So the ability to make inferences from these situations is just like a lost opportunity every day. So that's really what I'm up to. So I can probably come up with very good ways to turn it off, right? But the harder problem of like how the cell phone is working, and leave to these guys.
Then we're in trouble.
Thank you. So we'll have more discussion after, so you can keep your questions. And so it's coffee break now, so I'll ask you to come back in 15 minutes, and please visit the exhibit and see more. Thank you, Emery.